Hello, everyone. Thank you for virtually attending our session, Application of CDC Guidelines for Pediatric Mild Traumatic Brain Injury for Athletic Trainers. My name is Zachary Kerr. I am a professor in the Department of Exercise and Sports Science at the University of North Carolina at Chapel Hill. I'm joined by my colleague from the Centers for Disease Control and Prevention, Juliet Harbauer-Prupa, who works in the injury center there. And today we are going to share with you some of the CDC guidelines for pediatric mild traumatic brain injuries and how they relate to athletic trainers. So our objectives are first to describe the opportunities with implementing these recommendations for patient care by the CDC guideline for pediatric mild traumatic brain injury. We're going to identify best practice strategies for pediatric care for patients with traumatic brain injuries. And at the end, I'm going to discuss a bit about the challenges with implementing CDC guidelines potentially, as well as guidelines in general, as related to athletic trainers. Julie will have some of her disclosures listed when she begins to present. I wanted to share with you mine. I am funded by the CDC on a current grant. I am core faculty with the UNC Injury Prevention Research Center, and we're partly supported by an Injury Control Research Center award from the CDC, particularly the National Center for Injury Prevention and Control. And bullet points here of some of my current and former funding related to NIH, the Foundation, NOXI, the NFL, the NCAA, as well as USA Football and US Lacrosse Sports Center, Center for Sports Science. So before we begin, I thought it was important to just kind of give everyone some information about the CDC and what the CDC does and how the CDC was created. We hear currently, this is why we're doing a virtual conference, a lot about the CDC nowadays. And I thought it was important to just share some history and share some things that I was able to find about the CDC through my own research. The CDC has been around for over 70 years. It actually first opened its doors on July 1st, 1946 as the Communicable Disease Center, and it occupied one floor of a small building in Atlanta, Georgia. And its primary mission was really focused on preventing malaria from spreading across the nation. And its budget was only $10 million with fewer than 400 employees. And the agency's first early challenges included obtaining enough trucks, sprayers, shovels, equipment necessary to wage war on mosquitoes. Although medical epidemiologists were scarce in those early years, disease surveillance became the cornerstone of the CDC's mission of service to the state, and over time really changed the practice of public health. And this is very important for me, given my background as an epidemiologist and also with the focus on epidemiology as related to COVID-19 today. So since 1946, there's been a lot of significant accomplishments since the CDC's beginnings. And to accomplish its mission, the CDC is very focused on the conducting of critical science and providing health information to help protect the United States and the world against expensive, dangerous health threats, and also responding when these situations occur. The CDC's mission is really about conducting critical science and providing health information through a couple different focus areas, one of which being developing and employing world-class data and analytics for more targeted, quicker outbreak responses. The CDC really argues that this is not meant to be historical or even real-time in some cases. Rather, it has to be predictive. They want to stop things before they spread. And this is kind of the thing I've been talking with a lot of people about when it comes to public health. Public health's main goal is really to be this silent victor, this thing that is going on behind the scenes that we don't think about. We don't think about the fact that when we drink water that we don't have to worry about it potentially being toxic or chemical filled and thus hurting us. When we are doing our daily lives and we're working out, when we're going to the grocery store, we assume that we're going to be in a safe place. And part of that is based upon the efforts of public health. Public health is behind the scenes. It's being predictive. It's stopping things before they can arise so that the public don't have to think about it. At the same time, the CDC really focuses on state-of-the-art laboratory capacity Their science is shared across the world to solve real-world public health problems. So while there is a focus on the United States, it's also focused on the global health economy as well. It also focuses on quickly responding to outbreaks at their source, both locally, nationally, as well as abroad. It's about building a current foundation of the global health capacity and awareness, and it's really about upholding an elite public health workforce to stay on the cutting edge. The CDC scientists and health experts aim to be trusted and world leaders in disease, and hopefully one of our country's greatest assets. The CDC houses many different centers, and one of them is the National Center for Injury Prevention and Control, also known as the Injury Center. And like diseases, injuries are preventable. We can argue that they do not occur at random in most cases, that there are things that can be done to help prevent an injury from occurring. The CDC's Injury Center uses those same scientific methods to prevent injuries that have been used to prevent disease. So they carefully describe the problem through surveillance. They study factors that increase or decrease the risk for injury. They design and evaluate intervention strategies that target these risk factors, and then take the steps to ensure that the proven strategies are implemented in communities nationwide. So for many of you who are listening to this, you may very well know from my previous presentations or presentations that have been done by other experts in our field, this model created by Willem van Mechelen that is called the sequence of injury prevention, which is very similar to what I described based upon what the CDC uses as their scientific methods to prevent injuries and disease. It's definitely a good read. It's in Sports Medicine 1992, I believe. A very good read to understand the process of injury prevention. So within the CDC's Injury Center, there are three subdivisions: the Division of Injury Prevention, the Division of Overdose Prevention, and the Division of Violence Prevention. So the Division of Injury Prevention is what oversees efforts in traumatic brain injury and concussion. And the nice thing about the work of this Injury Center is that it's a constant evolving focus area and what they want to look at. And to the bottom right of your slide here is you can see the research priorities booklet, which is what is used to guide the center in identifying solutions, emerging injury and violence issues. It's used to encourage innovative research and to really help focus on the CDC's public health expertise. It is constantly evolving. It is a living document, and priorities and guiding questions will change to meet the needs of injury and violence prevention communities, researchers, scholars, and advocates. So when you go to the CDC website, you can actually find subsections for different things that are being examined. This is what the traumatic brain injury concussion website looks like. I have the URL listed on the bottom. Definitely a lot of good information about basic information, provider resources, data and statistics, as well as the heads-up education materials that have been in use over the past decade. Julie?
Thank you very much, Zach. And I really appreciate that history section. And I can add to that by saying the Traumatic Brain Injury Team is funded by the TBI Act. I believe the most recent revision is in 2018, but that supports our center's efforts to look at traumatic brain injury, and we really value our partners and the contributions that they've given to us in reviewing products, letting us know priorities, and really supporting traumatic brain injury across the country and in Congress. So we're very thankful to that. And I'll also mention, prior to the release of the guidelines, we released a report to Congress on traumatic brain injury in children, which was a 3-year effort to identify what are the issues for managing traumatic brain injury in children of all severities. So that's available on our website under reports if you're interested in reading in more detail. And today I'm going to talk about our pediatric mild TBI guidelines and give you a little background on how they were developed, what they're focusing on, and how you can, and some information on how they can be implemented in your community. The other thing I'll say is 3 years ago, we funded projects called Changing the Culture of Youth Sports, because we learned that a lot of our work actually is around mild TBI at the time of diagnosis. But we really wanted to look at some interventions that might prevent traumatic brain injury and also increase reporting in youth sports. So that's how Zach and I connected on this project. And I really appreciate all the interdisciplinary collaboration, especially with athletic trainers. I know you see a lot of children who have TBI. I have nothing to disclose. Now I'm going to talk about the pediatric mild TBI guidelines. So they were published in September of 2018, but this was a result of 4 to 5 years worth of work on a multidisciplinary committee. We had individuals from medicine, schools, athletic backgrounds who treat sports concussion. We had sports medicine folks. We really worked with a large group that took they reviewed 25 years of research prior to writing the guidelines. And there was a consensus-based guideline, and as we all know, the Berlin guidelines are all consensus-based, but there was no evidence-based guidelines for healthcare providers on how to actually diagnose and manage mild TBI. So as you can see, we were very interested in creating something that could be used across multiple settings for multiple mechanisms of injury. Sports is one of them, but also falls.
Before we move on, can I ask just a quick butt-in question, so to speak? So tell me a bit about the involvement of athletic trainers in the development, and maybe I'm jumping ahead too soon, but you can tell us a bit about what sort of value athletic trainers brought to the creation of this guideline.
Well, very much value, and I don't have the exact list in front of me. It is on the publication, but athletic trainers contributed a great deal because the importance of athletic trainers is you see injuries at the sideline as they occur. That was very important. And in many settings, the athletic trainer is the healthcare provider at school who recognizes these injuries and knows that they need to be taken care of. So as I said, it summarizes 25 years of scientific research, and it's the only U.S. evidence-based clinical recommendation for healthcare providers. Here's the healthcare settings that the guidelines were targeting at the time, but we also were looking at athletic trainers. And part of our work, we wrote, when they were released, we wrote commentaries or organized commentaries with several disciplines, including athletic trainers, which Zach will discuss, schools, neurologists, ED people, rehab people, primary care, the AAP, American Academy of Pediatrics. We really tried to extend the reach of these guidelines by writing commentaries to show how they could be applied in a specific setting. So I just want to talk about 5 practice-changing recommendations, even though there were 19 recommendations covering diagnosis, prognosis, management, and treatment. But the 5 practice-changing ones I'm just going to mention. So routine imaging for children was not recommended when you suspect it. And there's been more papers come out about this. Children are at risk for long-term effects from imaging. And what came out of the guideline review is that if you suspect there might be more internal bleeding or subdural hematoma, that's the time to do imaging, but not at the time when the child first presents to say that they have a mild TBI. What we want people to do is use validated age-appropriate symptom scales to diagnose it. And right now, there are some symptom scales on our website. The ACE is used quite a bit. These scales are really more appropriate for children age 5 and older. What we're learning about young children is they may show, children younger than 5, different symptoms based on because their age, because their parents are observing and reporting. So we're working to identify what might be used for that age group, but for now, it's very important to use these validated age-appropriate inventories to diagnose mild TBI. We also want physicians and healthcare providers to assess evidence for risk factors for prolonged recovery. This could be a history of brain injury or concussion, comorbidities such as attention deficit, disorders. And we published a paper in 2018 in JAMA Pediatrics from a national survey that describes some of the co-occurring health conditions related to TBI, hoping that pediatricians would have more information and all physicians on what co-occurring conditions are important to look for. We also want to provide patients with instruction on return to activity customized to their symptoms. And this is return to play and return to school. One of the things that's really important for healthcare providers to do is to provide discharge recommendations to families and educate them about what needs to be done when their child leaves the healthcare setting so that they can know how to monitor their symptoms and their return to all kinds of activities. So across the pediatric age span, although sports participation increases as children get older, young children return to physical education class and all kinds of playground activities. So it's really important that parents understand this. And also, return to school is another area that out of these guidelines, we are currently funding 2 projects looking at return to school programs and how effective they are in management of brain injury in children in terms of their health and academic outcomes. So this was kind of a start of looking at that to better understand what helps children. We also want to counsel patients to gradually return to non-sports activities after no more than 2 to 3 days rest. So some of the early literature was advising that children be in dark rooms and not do anything. And what we've learned over time is the importance of graduated activity geared to individuals and their symptoms. So make it an individual plan. And also not just rest the entire time, but gradually engage in physical activity as children return to play in school.
Can you tell me a bit about the process that was done to kind of look through these things and just what sort of conversations were happening during this meeting? There's a lot of research out there that talks about how difficult interdisciplinary or multidisciplinary type of project can be, and sometimes they're struggled with finding shared vocabularies or things like that. So I'd be curious to hear a bit more, and maybe the audience would be curious to hear a bit more about what sort of discussions were had, what sort of maybe points where there had to be a bit more deeper conversation were needed, or things around that.
One of the things that was happening during this time, so they reviewed 25 years of literature, but as we all know, the field of literature is currently evolving. So even in 2018, when all these guidelines were published, this was published, what was new in the field is, for example, vestibular testing. That was just starting to come around with literature prior to publication of the guidelines. I think the role of athletic trainers as healthcare providers, we consider the athletic trainers healthcare providers because you provide health information. I think knowledge about discharge instructions, what to include, and also what is an age-appropriate symptom scale. I think those were all discussion points that the final guideline, different groups figured out how to address them. And what's ongoing, so even though those guidelines are out and they're 2 years old now, and as we know, more and more literature has come out during that time. So I think some of the key points here about the imaging, about the need for looking at children more than just the concussion, but their overall history, and giving clear discharge instructions on how to go back to play and school. Those are the important considerations that I think were presented and discussed from these guidelines.
Great, thank you. And for those in the audience, I think it's very important to ask those questions when you hear these sort of presentations about guidelines and things about that, really get to know the methodologies done. It's sort of like when we look at research articles and peer-reviewed manuscripts. We can't just take the results for granted. We want to know a bit about the process. And I think the great thing about our field is that there are so many athletic trainers who are also researchers who have a very good understanding of the processes related to the guidelines that are out there, the NATA guidelines, the Berlin consensus document. And I know they're currently working on the update of the Berlin documents for, they'll call it Paris because it's going to be in Paris in 2021. It was actually postponed a year. But there's a lot of athletic trainers who are going to be involved in that. And I think it's important to have those conversations. And I think the great thing about our field in athletic training is that people are very approachable. People are very much in that team-based mentality, and it's okay to have these conversations. It's okay to ask questions. It helps us all become better practitioners, better researchers in the process.
Okay, so how do we get this information into practice? And we welcome any questions on this as you view this presentation, but I'll show you what we currently have available. On our website at cdc.gov, we have information for healthcare providers and parents. So one of the things we offer, and we consider athletic trainers healthcare providers, we currently have a training online, an EHR module, an overview of recommendations, and also for parents, discharge instructions, symptom-based recovery tips handout, and existing CDC heads up. And so here's some of the tools to give you an example that we have available on our website that you can use and give to families and other healthcare providers if you refer them from the playing field to a physician, these can go with them as well. And this mentions our heads up for healthcare providers training. So we talk about the guidelines, free continuing education credits, and it's part of our heads up concussion education initiative. You can look for this online. That's what I have to present. I want to make sure I give Zach some time to talk about how this applies to the discipline of athletic trainers. And I want to thank you for inviting me to be part of this. We really appreciate your work and look forward to working with you in collaboration.
Great, Julie. Thank you so much for your help and providing us with some additional information about the guidelines. So what I want to do for the rest of our time that we have with y'all is talk about how do these guidelines apply to athletic trainers, but also talk about some of the challenges with the implementation of guidelines. One thing that I've noticed during my work working with athletic trainers is that there seems to be guidelines for everything. And I always talk with the athletic trainers, the athletic training research staff at UNC about how do you just deal with so many different guidelines out there. There's one for traumatic brain injuries, there's one for ankle sprains, there's some for the knee, there's some for sudden cardiac events, there's some for dental injuries. So I can only imagine how much work it is. And I think what I hope to do is just sort of talk about some of these things in my next few slides here. So how do these slides and the guidelines apply to athletic trainers? Well, I think the first thing I can recommend for people to do is to consult the 2019 JAT publication that was led by Dr. John Register Mihalik. And I have the DOI and the article title page here on the slide so you can see it. You can see the title. I guess you could pause if you needed to and bring that up if you wanted to. But the two key things I wanted to emphasize that Dr. Register Mihalik provided in the text was, number one, the CDC pediatric MBI and TBI guidelines reinforce many constructs in the NATA sport concussion position statement, as well as the Berlin consensus statement. And number two, the guidelines did not supersede either position statement. They were meant to complement them in order to improve the management of children with mild traumatic brain injury. So the important thing to think about is that this isn't going to be one more thing to have to add to your to-do list. A lot of these things are going to be intertwined with the work you're already doing. So what I wanted to do right here, and this is one of the great things about a virtual conference, is that to pause us if needed. So you can pause and look at things a little bit more in depth or come back to it when you look at things later. And although this table, which is actually very large and I had to put into 3 different slides, is available in Dr. Register Mihalik's 2019 JAT article. I thought it'd be important to at least include so that those who are interested could actually take a look, see kind of what the CDC recommendations are, and then compare it to the corresponding NATA position statement recommendations. And the nice thing is that this includes level of confidence, and Jonna's paper talks about the amount of research or the amount of evidence-based findings that can back up some of these recommendations. And then you can also see how they intertwine into different topic recommendations, so to speak. So I'm hoping, I thought this would be one of the kind of nice things about a virtual conference. I can talk, but you can also look at it. So if you need to pause and take a closer look, please feel free to do so. The next part of the table here now focuses on return to activity, return to learn. This is going to be one where I'm going to keep pushing for, but again, I recommend if you must, pause, take a closer look, or find the original article to look at it, because it is a lot, but again, it's very focused on also what the position statement from the NATA recommends. And the last one, again, looking at severe persistent dysfunction, the footnotes are important because they talk about what these action levels actually mean. They talk about the level of evidence. So my hope is that this is going to be helpful. I know sometimes we can say, hey, go look at this article, but when you're in the matter of looking at a presentation, it's kind of a pain to do that sometimes. So I wanted to include these tables. Again, I'm giving this a shot. I've been thinking about doing this with my own online curriculum for my students coming up this academic year, just saying, hey, this is the nice thing about pausing something. You can pause and you can stop having to listen to me blabber for a while, and you can have the information right here to digest. So I hope this may be helpful. And if it doesn't help, definitely let me know so that I make sure I don't put my students through the misery that you may be going through right now. All right, so now that I'm done using you all as guinea pigs to see how slides and virtual NATA curriculum can work, I want to go into these areas of importance that Dr. Jonna, Register Mihalik's research team identified as areas of importance, and also emphasize what the positions statement meant in terms of what athletic trainers could do and what their role was in accordance with these TBI guidelines from the CDC. So the first area of importance is really focused on imaging, and Jonna et al. Really focused on the fact that although ATs may not be able to order imaging, they can really assist with related education for the families and also the inquiries from the family. And I apologize for the typo there. Inquiries is spelled wrong. Pet peeve of mine is when I particularly do typos, but y'all can see they get the message. But the big thing is that education for the families. Families may have questions. I always make the joke that parents are very much like parents of any animal. You don't mess with their kids, whether they're a bear, they're a human, they're a wolf, or anything like that. And parents are going to be very cautious and very much asking questions about what sort of things are being done for their children to provide care or what could put them at risk. So I think it's very important to be able to provide information as an athletic trainer back to those families. It's also important because in many cases, in many settings, particularly in high school settings, and maybe in some rec sport or middle school settings where they are fortunate enough to have athletic trainer presence, the athletic trainer may be the first point of contact where they can provide some of that education and provide some of that information that's going to be helpful for their families. Second of all is assessment. And again, this is very much similar to what the NATA position statement and the Berlin consensus guideline talks about, the use of valid, reliable, age-appropriate tools, understanding their properties. And just to give some research methods 101, validity is all about focusing on accuracy. Are you actually measuring what you're going to get, what you intend to get? Reliable is focused on consistency or getting the same measure at the same time. And so when you have a valid and reliable measurement, you're going to be able to get accurate measurements again and again and again consistently. So I use the metaphor or the imagery of a scale. A valid scale is going to give you your correct weight. a reliable scale is going to give you the same weight over and over again. So we want them both to be valid and reliable. A reliable scale that isn't valid is going to give you the same wrong weight over and over again. We don't want that. That's not good. Age appropriate tools is really focused on making sure that you're providing tools that are going to be comprehended by the concussed young adult or the child. We always talk about, symptomology scales, and you can't ask a 5-year-old, are you suffering from tinnitus? The 5-year-old isn't going to know what tinnitus is, let alone many people who are adults as well. You want to make sure you're using vocabulary that is going to be understood by the person in question. And the great thing is that there's been a lot of research of different tools that can be used for those younger populations. So, for example, you can ask a child, do you have an upset stomach, or does your tummy feel sore, instead of asking about nausea or things like that. So one thing that is mentioned is there is really no stand on baseline testing within the document. But the best thing to do is to follow best practices and mandates within your setting as an athletic trainer. So it's important to have an understanding about what the state mandates, what the national mandates are, what are the recommendations, what are the best practices. And again, as with imaging, it's all about education. Educating families about limited knowledge available about different things. Particularly, I would want to mention biomarkers for MTBI diagnosis. There's a lot of research now about biomarkers, about being able to predict someone who's at high risk, someone who's at prolonged recovery potential. And the research on biomarkers is still so much in its infancy. So it's going to be great, and we're going to learn a lot of things in the next couple of years or decades. But right now, the knowledge is very limited, and I think that's important to emphasize to parents as well. Patient and family education was the next area of importance that John et al. Talked about. And it's really important to focus and talk about commonly seen factors associated with the onset or what causes a concussion, how common concussions are in different settings, what sort of symptoms are more common than others, what sort of symptoms may be rare but may be a red flag for something to think about, what sort of recovery curves or recovery or treatment or management options may exist. But I think it's also important to say that each concussion is different. And, there's a couple different terminologies or sayings that are out there. One is, if you've seen a concussion, you've seen one concussion. And one I like that Dr. Kevin Guskowitz uses, one of my mentors and now chancellor of UNC, is that every concussion is like a snowflake. Not one is very much like the other. There are similarities, but each one is unique and different. So it's very important that ATs can help inform and support development of these individualized recovery plans. And of course, for family education, it's about talking about warning signs, home care instruction, and also an emphasis not only on returning to play, but also returning to learn in the education setting in which the child attends. Next one is determining risk for prolonged recovery. So ATs can help athletes whose medical histories may increase the risk for prolonged symptoms. It's always important to get a grasp on who the athlete that is concussed, what their history is, to be able to understand if those things may increase the risk of prolonged recovery. This can be simple things as, have they had a previous concussion history? As we find that research has shown that those who have one concussion are more than likely to have a second concussion, and perhaps maybe even worse outcomes related to the second concussion versus the first. Here's the awesome thing that I love about athletic trainers. They have such a good scope on understanding and being able to work with athletes. Many times their athletic trainers are going to know best about what's up with the athlete because they see them day to day. There's actually some really interesting research that was done maybe 5 to 6 years ago, and I haven't seen much of it now, but I'd love to see more of it. Hint for those athletic training students who are looking for doctoral degrees or further research. I'd love to see some more focus on looking at how well athletes identify with athletic trainers, because there's been some research that says that athletic trainers may be someone who athletes can identify the best with when they're talking about working with adults in a sports setting. You have the coaches, you have the other parents, you have the officials, you have the athletic trainer, and there's been some research that has suggested that the identification that athletes feel with athletic trainers is a bit higher than those other adult stakeholders. I'd love to see a lot more research on that, particularly focused on when you look at racial discrepancies between the caregiver and the athlete in question. There's a lot of research out there about doctor-patient dyads and how racial inequalities can affect that relationship. I think it's very important to look at that with athletes and athletic trainers, particularly when, in many cases, our athletic population are persons of color as well. Lastly, the last bullet point I want to emphasize is this and other factors collected can help inform management and treatment plans created by the concussed athletes' primary healthcare providers. You have this information. It's very important to be able to share as much information you can with the primary healthcare provider. Return to activity, return to learner school are the next points that Dr. Register Mihalik has emphasized. The emphasis is on fully returning to school before pursuing full return to physical activity. Again, since the athletic trainer is available in many of these settings to monitor daily symptoms and perform assessments, recovery process, that's going to be very important. And also ensuring that use of a referral system is necessary. I see this a lot in a lot of fields that provide public health services. A lot of times there's so much pressure placed on one individual that they get stressed, they get burned out. But I think it's important to realize that in many cases, you want to think of yourself, hopefully and ideally, as one piece of a system where you're doing your job to help the system run effectively and efficiently. So hopefully the use of referrals can help ensure that when you may feel that you don't have the expertise, there's someone else available who can provide that instead, or to help complement the skill sets that you have. Return to learn or school. This is where the CDC guidelines do expand upon what is found in the NATA position statements and Berlin consensus document. You're going to find in that document a lot of extensive recommendations regarding the return to school process and also the psychosocial considerations that may be useful for athletic trainers. So it's going to be about not only return to activity plans, but also maybe working with teachers to help figure out what's that individualized return to school plan for individuals who are concussed based on their symptoms. So again, it's going to be very much a team effort using referrals based upon what you know as well as what other individuals know. And one thing I did discuss with Julie in one of my questions is understanding how difficult it can be working in collaborations where there's many different stakeholders who come from many different backgrounds. I think you hear a lot of these buzzwords, interdisciplinary, multidisciplinary, but it's much harder to do in practice. So you have to make sure you have communication. You have to make sure you identify shared vocabulary, but also you have to make sure there's time to acclimatize with the different group members that you're working with. Find time to be able to understand what one another's perspectives are and why, so that it can help you more work efficiently as a team. So in summary, many of the best practices from the NATA statement and Berlin consensus are reinforced in the CDC guidelines. And I do feel that ATs are a part of an integral team of healthcare providers. And one thing I would like to emphasize is that similar documents, such as the one written by Dr. John Register Mihalik et al., are available for colleagues in other fields and disciplines. So there's work being done for not only this group of individuals, athletic trainers, but others as well. So moving on, this is great that we have these dissemination tools, these tools for policies and guidelines, but the research has shown that sometimes it can be a struggle to actually implement these things efficiently and effectively. So just a couple studies that I pulled out here that are looking at a couple different settings. So not all pediatric settings, but three that I felt were important to bring up. Tracy Govason from Michigan State found in 2009 that 61% of ATs and educational physicians use the NATA statement in a clinical setting. Rob Lionel from University of Georgia in 2013 found that 69.3% of practicing ATs were familiar with the NATA statement. And at a time when I was doing work with the Daedalus Center in the NCAA in 2015, before the NCAA was actually requiring concussion management plans to include baseline testing, from the sample that I looked at, 43.7% of NCAA member institutions that were responded to my survey actually noted that they complied with baseline testing recommendations. And a lot of this was mostly due to a lack of the balance testing, not the baseline testing. That's another typo there. But it was the balance testing that was the hardest part to actually have full compliance with. So this slide is really showing that there are struggles to actually have practices implemented based upon dissemination. So it's important for the research community to help figure out what sort of tools can help facilitate implementation and what can help deter barriers from occurring. So looking at this study that I did in 2015 with my colleagues, this is looking at my results based upon Division I, Division II, and Division III. And you can see that the highest compliance was with D1. Highest compliance with the baseline testing was D1. And similar findings were actually found when you were comparing NCAA member institutions with football versus without football. So there's different factors at play that are helping to allow for facilitation of implementation of these guidelines, but there's also perceived barriers that can occur. And in this case, we hypothesized that it was something about resources potentially available with member institutions without football programs are in D2 and D3 divisions versus D1. Moving to a pediatric population, Emily Crocius and myself in a 2017 study looked at the USA football Heads Up Football educational program, which is different from Heads Up Football created by the CDC. But in the USA football Heads Up certification process, they require their coaches, or they did require at the time, because it's a much more fleshed out program now, much more online. We were looking at certification of the coaches, which is a required component, but we were able to get data from USA Football to tell us about what percentage of the population of coaches actually did comply with this requirement for Heads Up Football. And we broke this down by census region, and we found that the census region 5, 6, and 7, so South Atlantic, the East, South, Central, West, South, Central, from Florida up to Delaware, down to Tennessee, Mississippi, Texas, Arkansas, Oklahoma, the lowest percentage of compliance within that census regions was found in those three. And when we did some multivariable modeling, we actually found that in those areas in which Heads Up Football certified coaches were in communities with smaller percentages of certification, it also happened to be those communities that had higher percentages of families with children under 18 living below the poverty line, as well as lower percentages of non-Hispanic white residences. So when we talk about these factors at play, there are many different things that may mitigate the ability to have proper implementation. It may not just be at the individual level, it can also be at the organizational or community level as well. So this is where this is one of my favorite slides that I create, but this is focused on this idea of pro-equity research, which is really focused on thinking about where we do research and how we can expand our reach to ensure underserved and underreached communities are also reached. So the best way I can describe this is think about the slide here showing a quality of life spectrum. So the further you are to the right, the better quality life you and your community have. So we have community A and we have community B. Community A has a better quality of life because they're on the quality of life spectrum farther to the right in this illustrated example. Now, this formatting that UNC research does not help, but you see that blue line underneath the dotted line that showed up there. That difference between community A and community B is what I consider to be disparities. And we don't know what that disparity is yet, but it's just a disparity that we're going to use for this illustrated example. So when we as researchers do interventions, sometimes we have to accept the fact that we're going to do convenience sampling, that we're going to go in our own backyards. But when we go in our own backyards within a university community, we're going to see that our communities are going to be much more educated, have higher socioeconomic status, higher income, higher quality of life. And when we do our interventions and only provide them to that better community, then we're only helping that better community. And for lack of better terms, the rich get richer and the poor stay where they are. And that disparity is exacerbated. So we try to do interventions and we try to provide them for both intervention A, which we are part of the community of, as well as this other community, which we're trying to understand and trying to get a better sense of. But it's very difficult at times to be able to figure out how to gain trust and how to be able to talk their talk, or that we can build trust and confidence with those individuals. So a lot of research now is really emphasizing patient voices, community members being involved in research to ensure that we as researchers are taking off our privilege hats, taking off our supposed stereotypes of these other communities, and doing a better job of giving them what they need and what they want to be able to get the results that we want them to get as well. But in the case of us kind of just trying and not really doing these things, well, if we provide an intervention to both communities, it's likely that in community A, this is going to work great. In community B, when we don't have much success, much buildup, in the words of Randy Jackson from American Idol back in the day, it's all right. It's all right. It was all right. A little pitchy, but it's not going to work as well. So community A, they're going to get the results we're hoping for. Community B may get some results, but it's still not going to be the change at the rate that we want. And once again, the disparities are going to be found there. Now, what differentiates community A from community B? Well, it could be based upon so many different factors: location, whether you're in the majority versus minority, high socioeconomic status, low socioeconomic status, being a member of the LGBTQ plus community or not, being English speaking versus non-English speaking, near a college campus, not near a college campus, D1 at times versus D2 or 3. It could also be in a non-emerging sport area where a new sport's coming into an area where there's not much knowledge, not much education. It could also be, local. I don't know if people know this term, but it's a term I hear a lot within some of my friends. Is you have states that are flyover states. You just fly over them. You never want to go there, and that does provide a disparity, or something that could provide lower quality of life for individuals who are trying to get some public health work done there. So, how does this apply to this study? Well, I think there's strategies that are going to be important for everyone to consider, but I think there's also going to be strategies for implementation that are going to be specific based upon what their community is, who's in the community, what their needs are, and we have to be aware about that. So great starts are being done by different teams to look at strategies to implement youth sports setting concussion laws. This study was done by Davies, as well as I think their lead author was Ginger Yang from the Nationwide Children's Hospital Center for Injury Research and Prevention. And they talk about a couple different themes about removal from play, return to play, and concussion education, and what can be done to help implement youth sports concussion laws. I think the next step after this is going to be really focusing on what different factors are going to help certain specific communities. Because based upon the work that a lot of us in our field have done, we want to apply the socio-ecological model into our framework. So policy isn't just about what's going on at that level, it's also what's going on at these multiple different levels that exist, from legislation, policy orders, at the district level, at the conference level, what are physician standing orders, as well as any other associations that may be relevant. And this policy level is so intertwined with different things, but at the same time, it's one part of this larger socio-ecological model that includes the athlete, their relationships with coaches, with parents, with officials, with fans at times, the larger community, as well as society. And the idea of the socio-ecological framework, and if you're a reader of Journal Athletic Training, you're seeing a lot of this being more discussed related to not just concussion, but also sudden cardiac death, heat prevention, or heat illness prevention. And the idea of this is you're really just identifying what is going on in all these different levels and where interventions need to take place. They may take place at all these levels. They may take place to be more effective at one particular level versus another because there's a need for more attention there. But it's really all about how these are intercorrelated and associated with one another. So where the CDC fits in is that they want to provide free and publicly available educational tools to support athletic trainers' use and implementation of the CDC guidelines. The link is here. It's available for you to check out. This is a screenshot of what the site first looks like. So you have resources for parents, for providers, for youth sports, for school sports. You can find it on social media. Probably for athletic trainers, it's going to be important to look at, first of all, the heads up for providers, as well as perhaps youth sports or school sports, depending on their setting. And maybe also important to look at parents just to see what the CDC is recommending as well, so that there is, once again, that shared language and making sure that you're providing information consistently as well. The heads up tools for healthcare providers. This is a picture of the page that you will go to. So as Julie mentioned, online concussion training, tools, ideas for return to activities, as well as a lot of different multimedia resources available, from PDFs to mobile apps to videos, graphics, podcasts, social media. There's a whole gamut. A lot has been thought about what is being done here to help provide as many resources available to healthcare providers in different manners that may work better for people based upon their mindsets, what works for them, what's the best way they can learn as well. I think it's important to, in close out, talk about why this is important, why we want to think about kids' safety during sports and traumatic brain injury guidelines. So the percentage of kids who regularly participate in high-calorie burning sports has gone down since 2011. And this information is from the Aspen Institute. And you see that the number going down, but at the same time, the number of physically inactive children has actually decreased slightly as well. This is sort of a graph that is a little deceptive. It is showing some drop, but I think the key thing I want to emphasize is that the percentage of physically inactive individuals who are 6 to 12 does increase when you start stratifying the results by lower household income. So individuals who are from families with higher incomes, that percentage of inactivity is going to be much lower than those children from families with lower socioeconomic status. From a population sense, prevalence of overweight and obese children in 16 peer countries, so countries that we can compare ourselves to when it comes to socioeconomic status and things like that, we are at the top. And this is a race where we do not want to be number one. The prevalence of overweight and obese children in our country is much higher amongst females and males. And it's important that we want to make sure our kids are active, because the research has shown that there are so many good effects for children when they're physically active. And I do love this slide from the Aspen Institute that really shows what happens as you become adolescent to an adult. And the most important thing is that when you as a parent are also active, that it helps create that mindset and that behavior for your children to follow as well. So this is why I do the work that I do. I'm not an athletic trainer, but I'm an injury epidemiologist, and I love the work that I do, but I want to make sure that it's important that we take a step back and think about, why are we doing this work? It's because we want to ensure our kids are safe so that they can become healthy, active adults and continue this cycle. Sports play a pivotal role in helping kids become healthy on all levels: physical, social, emotional, and cognitive. So I think that's where I want to end this presentation today. I want to once again thank Julie, as well as the NATA, for helping us set up this presentation for you. We do want to have discussions, so here are our email addresses. Please feel free to email us. Please feel free to shoot an email. One slide I usually do show that I didn't and forgot to show is that particularly in these times with COVID-19 and the pandemic, it's very important that you have a support system, and I hope everyone has that and are taking care of themselves. It's tough times, but we got to get through this together, and this is very important for you to check in on loved ones and make sure that they're doing okay, just as much as they need to check up on you and make sure you're doing okay. Because once again, it's going to be about your physical health, your mental cognitive health, your social health as well. So make sure you do reach out to your support systems and take care of yourselves. And also, as athletic trainers, make sure you take care of your team of athletic trainers as well as your athletes as well. Make sure that you can be the best person you can be, particularly during these hard and trying times. Thank you so much.
Thank you, everyone.